Very good morning to all of you. And first, at the outset, I would like to thank the Dean, the national level organizers, and Professor and Head Department of Pathology, Kamal Madam, for giving me this opportunity. My topic is histopathology of immunobulus diseases. So, as Sir was telling about bullous diseases, there are nomenclature saying that vesiculobulous diseases, but I will be restricting my talk only to histopathology of the immunobulus disorders. Since otherwise it would not be possible to complete the lecture in half an hour. I have given the subtitle of Blebs and Bubbles and Poxes and Foxes. Some of them are very clearly यहाँ दे दो ना माउस इसको यहाँ पे इससे करना ये इससे some are very clear, like the infectious fevers, particularly the exanthematous fevers which begin as poxes. One of them is presently going on, so that is not part of my lecture. So what I will be covering is some other conditions, but before that, significance of immunobulus disorders. The immunobulus diseases, they are important for us because the incidence is increasing because of increasing life expectancy, and many of these diseases, they occur at the middle or late age of life. Life expectancy has increased, and therefore we see more and more number cases of these conditions. Secondly, they affect the morbidity and mortality plus the quality of life of the patient who suffers from these diseases. Some of these conditions are dermatological emergencies. For example, pemphigus vulgaris, it can be present right from the birth of the child. So that becomes important, and it is to be separated out from other bullous conditions. Then many of them are associated with neurological diseases plus neoplastic diseases. So pemphigus must be remembered as a paraneoplastic syndrome, for which we are quite familiar. Many of these conditions now, with progress in immunology and in direct immunofluorescence and indirect immunofluorescence studies, plus the various other immunological studies like ELISA and Western blot, many of the specific antigens have now been recognized, and because of that, they have been later on tracked to the specific gene which is responsible for the mutation in case of mutational. So the immunobulus disorders now can be treated as with the new immunotherapies, and that's how it has improved the prognosis, and we can offer specific treatment to the patient. Now in this lecture, what we are going to include are the immune diseases. Let it be clear. In intraepidermal, we have got mainly the pemphigus group of disorders. I will not name all of them right now. And then the subepidermal group of disorders. The pemphigus group most of them are intraepidermal. Okay. Now within intraepidermal also there are two compartments, that is subcorneal and suprabasal, that we know. Some of them are subcorneal and suprabasal, but together they can be considered as intraepidermal, and then the major is subepidermal. In subepidermal also there is a group of disorders, that is bullous pemphigoid, in which the hemidesmosome is the target structure to which the autoantibodies are produced, and hence that can be categorized differently. And then the deeper part of the epidermis. So deep dermis, that becomes, or the basement membrane zone, that becomes another point of attack by the pointer movement kaisa hai? So in subepidermal we have got bullous pemphigoid and its variants, and linear IgA disease, which is also called as the chronic bullous disorder of childhood, and there is adult form also. Then epidermolysis bullosa acquisita. Basically, epidermolysis bullosa is a genetic mutation-based disease, but in case of acquisita, there is production of autoantibodies, and that is an acquired condition. Then bullous lupus erythematosus. It has got only that it has bullous presentation, but because the basic mechanism is autoimmune, that's why it is included here. And lastly, the dermatitis herpetiformis, although it is not seen very commonly in India, it is related to gluten hypersensitivity. Now, what are the group characteristics? All of them are autoimmune diseases. Target antigenic sites and proteins have now been identified. They may involve mucosal, they may be only mucosal, they may be mucocutaneous or cutaneous. And most of them form the bulla, that is the large, more than 5 millimeter sized fluid filled cavities. That is the basically lesser than 5 millimeter, and bulla is more than 5 millimeters. But all bullae must begin as vesicles. So one has to remember that. There are many overlaps. The overlaps are in clinical findings, of course, and in histology. And therefore, final diagnosis has to come from immunofluorescence studies. So unlike the psoriasis form, where you can actually finally, you can reach the end point. Here we are only going to come to a point after histological findings as to what is the location of that particular split, as it is called. Now for this, we have to start with desmosome complex. It has got certain a structure which between the keratinocytes you have got the desmosome, and it is composed of many proteins. Desmoglines are the ones for which antibodies are produced, and in certain cases desmocolins, against them also the antibodies are produced. I've just named so that you are familiar with the terminology. DSG is desmoglin, DSC is desmocolin, and then there are certain connecting molecules which impart the integrity and attachment and the adherence of cell is maintained. Next we go to the how the cells are attached to the basement membrane or the stratum basalis. Here there is hemidesmosome complex. Now in hemidesmosome complex, it is the bullous pemphigoid antigen 1 and 2, and then certain other structures which are the anchoring filaments. I will not be going into each one of them because they are present in different diseases, but one has to start with knowing the bullous pemphigoid antigens because they are present in most of the bullous pemphigoid and its variants. Now, understanding pemphigus vulgaris, there is some important concept called as desmoglin compensation theory. Now, the structure of desmoglins is such that it is present in skin as well as in mucosa. But in the skin, you can see on the left panel that skin, their DSG, that is desmoglin 1, that is shown as a big trapezoid, and that gives the structure. And that gives the structural integrity. Whereas the desmoglin 3, it is falling short of the top layers. The triangle is there and it is not reaching up to the top of the epidermis, and therefore in case of pemphigus foliaceus, this desmoglin 1 is insufficient because anti-desmoglin 1 is attacking it, and desmoglin 3 is not sufficient to give integrity, and that's why you get a subcorneal or the superficial blister in case of pemphigus foliaceus. In mucous membrane vulgaris, pemphigus vulgaris, the situation is different. Here anti-DSG3 is produced, and here it is the main integrity is maintained because of the DSG3 in case of mucous membrane, and therefore you get suprabasal split in case of mucous membrane pemphigus vulgaris. The third is a combination where both antibodies are present against DSG1 and DSG3, and this is our classical mucocutaneous pemphigus vulgaris. Now, steps to diagnosis. Previously also we have seen that clinical evaluation, age, sex, type of bulla, flaccid or tense, these are important indicators. Then whether it is only cutaneous, mucocutaneous or mucous membrane is involved, all these findings are noted by the clinician. Whether they are vesicles predominantly or bullous regions are also present. In the pattern of distribution, it is specific for a specific condition. Presence of pruritus. Extreme pruritus sometimes does not allow the vesicle to stay. They are just like that. And most of them get excoriated and a crust is formed. And you won't see that in most of the patients when they present clinically. Then the clinically important Nikolsky sign and bulla spread sign is done. And then after this, the dermatologist would arrive at a clinical differential, and then he might take a simple biopsy, lesional biopsy, and if he intends to have, and the facilities are available, he would like to take the peri-lesional biopsy to be sent to higher studies on immunofluorescence. Now this is showing the skin biopsy. You can see the peri-lesional skin. This is a punch being taken, and it has to be processed specifically separately. Either you send it in PBS, phosphate buffer saline solution, and it is sent in a cold chain. Cold chain maintenance is then important. And then frozen section and DIF studies are done. Or if you want to send these samples at a long distance, then Michel's medium is available, but I was told it is not available and it is not used, at least not available in most of the cases. Second is for indirect immunofluorescence. For indirect immunofluorescence, you would require the patient's serum. And then there are certain chips and certain methods of knowing the antibodies, and they react with the animal substrate or normal human skin, and that's how the diagnosis is finally pinpoint diagnosis of that particular condition is made. Now there are 6 common problems that we encounter when we deal with a bullous disorder. First is that the site of the spirit may change as the blisters age. The subcorneal may get increased in size or may become secondarily infected and reach up to the base by destruction of the epithelium, and may appear as if it is a suprabasal. Secondly, there are many mimics like genetic clefting diseases like Darius disease, Haley disease and Grover's disease, which have again acantholysis as a common etiological mechanism that it shares with pemphigus vulgaris. Third is specific mechanism of blister formation is not apparent as clue to the diagnosis. So you won't be able to always see acantholytic cells if it is secondarily infected, right? Fourthly, the infiltrating cell types also change over a period of time and they are not constant or very specific for a given condition. That's the problem. Fifthly, absence of facilities for ancillary tests, because finally you have to rely on the DIF studies, and the diagnosis comes only from DIF or immunological confirmation by indirect immunofluorescence or other methods. Finally, lastly, the therapy-related changes. Sometimes the biopsy is delayed. Initially, treatment trial is given, and later on the biopsy is taken from that. So that was about the care to be taken. Now coming to pemphigus vulgaris as a group, I will be telling about certain group characteristics you start with, so that we cover some part of epidemiology and the frequency at which these diseases are occurring, and the basic definition. Pemphigus is a group of acantholytic conditions caused by autoantibodies necessarily, and various epidermal cell junction proteins. They are the targets of these autoantibodies. Commonly they present with flaccid blisters. Now these are occurring in the epidermis. All these changes are occurring in the epidermis, and therefore the fluid can be shifted from one to the next, to the adjacent, because already there is acantholysis also. So that favors the movement of the fluid. So, and they are also very easily prone to get ruptured, and that will produce erosions or scaling. There are 4 main forms of this: pemphigus vulgaris, pemphigus foliaceus, paraneoplastic pemphigus and a newly described entity called as IgA pemphigus. Now it is, as in the rest of the top three conditions, it is the IgG antibody that is present, and this was recognized later on, and it is newly described IgA pemphigus, where the intercellular fish net pattern is seen on immunofluorescence, direct immunofluorescence, which has identified this condition only about 2 decades back. Now, in most of the pemphigus vulgaris group, common factor is there are antibodies at least to desmoglin 1 and 3, and in addition there may be some other autoantibodies may also be produced. Pemphigus vulgaris group, epidemiologically, if we consider, the most common is the pemphigus vulgaris in this group, and it is common in India. We see many cases. Average age of onset is 40 to 60 years, and it may affect even a neonate via transplacental autoantibody transmission, just like you have Rh incompatibility and there is transplacental IgG transfer. Similarly, this can happen, but it is not very common here. Pemphigus foliaceus, the average age remains same. Most common form of pemphigus in Brazil, where a particular type of fly bite is thought to be responsible for initiating event, and it possibly exposes the antigen, and that's how you get pemphigus foliaceus in the countries like Brazil and Tunisia. Paraneoplastic pemphigus constitutes only about 5%, but it is important to recognize it because there is underlying solid or blood cancer. Now, what are the various antibodies that are produced in pemphigus vulgaris? IgG antibodies to desmoglin 1 and 3. Pemphigus foliaceus, IgG antibodies to desmoglin 1. Paraneoplastic syndrome, again, IgG will be produced to desmoglins plus to desmoplakin 1 and 2, plectin and other periplakin and other constituents also. In IgA pemphigus, the deposition between the cells, between the desmosomes, the IgA attaches to the various components, particularly the desmocolin 1. That is the difference. Now, prognosis, historically, the 5-year mortality on old days for pemphigus vulgaris was more than 90%, and the patient would die because of various kinds of sepsis that he would develop because of so many excoriated lesions on the body surface. Now it is improved over because of the oral steroids and steroid preparations plus other immunotherapeutic agents available now. The poorer prognostic factors right from the beginning are the younger age at the presentation, mucosal involvement at presentation, and relapses. They are the poor prognostic indicators. Paraneoplastic syndrome, of course, the prognosis would depend on the malignancy causing it. Now coming to some, having considered all these basic things, now we'll rapidly go through the various appearances, images that one has to familiarize himself with. The first is the pemphigus vulgaris, where you are seeing this is an exceptional situation where intact oral lesion is found. Usually these oral lesions, the blister, tense blister, it breaks off very easily even on the skin, and in the mouth because of mastication, it is very rare to find such a blister or oral mucosa. This is one of the case. Secondly, when advanced and when multiple lesions are produced, you get the crusted and some amount of hemorrhage and necrotic matter is also present there. Same again actually. Here now we are seeing a case where there is skin lesion is seen. You can see two flaccid bullae and one confluent area of bullae which have ruptured, and it has produced a large raw area. Okay, so depending on this surface area involved, the prognosis and the treatment and everything is important relating to that. Next is the same affecting the front, back and scalp. You can see that the lesions can be very minimal to very extensive. This is a sort of collage of pemphigus vulgaris in which you see oral mucous membrane erosions, erosions on the hand, erosions on the knees, erosions on the back, because these are flaccid and they rupture very easily. Then superficial erosions, erosions on the scalp, and then last picture is important. There can be verrucous plaques. This is a variant of pemphigus vulgaris in which there is verrucous hyperplasia when it is healing. The mucosal pemphigus vulgaris, it is quite easy for all the pathologists over here to identify the suprabasal cleft. Here there is no question about the suprabasal cleft. It is nicely seen over here. You can see that there is no keratin layer and this is coming from mucosal layer. Now this suprabasal cleft, in case of skin, it would show the basal cell remaining attached to the dermis, and blister cavity usually ruptures, because as it is in its natural course also it ruptures very easily. So while performing the biopsy, many a times you won't find any roof for the pemphigus vulgaris cavity. This is low power, so I will not tell any. This is showing nicely the tombstone appearance, where the basal cells are remaining attached to the dermal papilla. The rest of the upper layer is gone. We are not actually able to see the contents of the blister cavity. One important aspect sometimes will be what are the contents of that blister cavity, whether polymorphs are present, eosinophils are present, or whether fibrin is present. But that is not that we usually don't see. Next is pemphigus vulgaris. The bulla is here, can be identified. It is a somewhat large cavity now with top layers also visible over here, and the bulla is in suprabasal location, that you can appreciate. Next, here the entire roof has gone away, and you can see only the basal tombstone appearance, which is very, very classical. Acantholysis. We talked of pemphigus vulgaris as mainly the acantholytic disease and autoimmune disease. In this case, you can see the acantholytic cells, they become rounded because of the centripetal force, and they don't retain their polygonal shape. And this can be, this used to be demonstrated in Zank smears. When facilities are not available, even now it is being practiced at many centers. Apart from the skin and the basal layers of the dermis epidermal junction, there is extension of this process even in the hair follicles. So you can see that between the hair follicles also, you can observe here that their spirit can be observed at the suprabasal location. You can see here intact hair follicle, somewhat deeper, but that process has started over here. Now, based on this, one interesting finding that has recently been found is that sometimes you may not find anything in the cavity, you may not find any cells, but you may find free-floating hair shafts. You can see on the left panel there are hair shafts, and on the right side you can see the sebocytes. Okay. So these when you see these changes, they are not seen anywhere else. So this becomes the pointer to this condition being because just beneath this left-hand side diagram, you see that there is multilayering. Some amount of reepithelialization possibly has occurred, or this may be at the edge of the blister. The edge of the blister, you can see multilayering. Normally one would expect a tombstone appearance here, just as you are seeing over here. But here, these are very important. These will give you a clue that in fact split is occurring at the suprabasal location. One more clue that people have been looking for as to how to identify an early case of pemphigus vulgaris is attachment of the eosinophils to the desmosomal junctions at the away from the lesion. Away from the bulla, sometimes you find that there is some amount of collection of fluid, that is some spongiosis is seen over here, and then in this circle you can find a eosinophil attaching here. In this also you can see eosinophil getting attached over here. That can be sometimes the clue. This adjacent diagram is showing the same. This is the epidermal cells, and which are not part of the blister, but you can see many eosinophils are attached to the the desmosomes. Now, as far as diagnosis is concerned, there are certain cautions that the experts have given. One is that while reporting, you should not misinterpret certain findings of pemphigus vulgaris as something different. For example, the regeneration atypia. Regeneration may cause confusion as to whether it is suprabasal or it is a subcorneal extending right up to the base. Regeneration is one. Second is regeneration associated atypia. That sometimes can be mistaken for squamous proliferation, which the part that I have at the pointer it is showing. And then sometimes you also see the multinucleation, and it may be misinterpreted as herpes infection. So this is the master diagram or collage of the various changes that we have seen so far. Tombstone appearance, the formation of these villi, which are lined by the basal cells, which remain attached to the dermal papilla. Now here you can see in the third diagram, you can see that there is a involvement of the suprabasal in the hair follicle also. Although there is no blister, but you can see the line of suprabasal location, the split has occurred. This is the same again at higher magnification. So this was all about the microscopy or histopathological findings of a classical case of pemphigus vulgaris, which is the prototype of the pemphigus group of conditions. Next is the pemphigus vegetans. In case of vegetans, there are two types, and one of them has a benign course and one has got slightly different course of clinically uncommon variant, only 1 to 2%. While healing, this develops into verrucous like epidermal hyperplasia. There are those two named types are there. The Newman type is more severe, and the disease begins and ends as pemphigus vulgaris, but many of the denuded areas, they heal with verrucous vegetations and may contain small pustules right at the early stage. Sometimes presence of pustule can mislead you to certain other diagnosis, but otherwise it is not different. The Halopiu type is a relatively benign, and it has pustules as the primary lesion. Right from the beginning, the pustules are present, and there are no bullae to be found in this. So these two are the, now its gross appearance actually would show you the why it is pemphigus vegetans. You can see that single plus additional one here. This is the healing process occurring in a pemphigus vulgaris, and while healing it is giving this appearance as a solitary vegetative plaque. Another case of pemphigus vegetans in which the flexural surfaces are usually involved, and there are numerous intact vesicles containing lot of neutrophils, that is the pustules. Same at higher magnification, you can see the intraepidermal abscesses, and they are composed of eosinophils and a few acantholytic keratinocytes. So within pustule, if you find that there are a few acantholytic cells, then you may suspect that this may be a case of pemphigus vegetans. In this case, the hyperplasia, you can appreciate the hyperplasia, right? So many layers of are formed, and then keratin is also formed at the top, and suprabasal cleft is seen over here. The healing stage of pemphigus vegetans. Next we come to pemphigus erythematosus. This has a overlap with this has pemphigus plus SAD. You can see here the butterfly rash typical, and in addition the lesions of pemphigus vulgaris. I won't show the microscopic of this. Next we come to the another second major group of pemphigus group, that is pemphigus foliaceus. In pemphigus foliaceus, the blisters are fragile and erosions are usually very common because it is very superficial in location. It is subcorneal. Just beneath the stratum corneum, these lesions are there, and they break off very easily. The acantholysis in this case is very subtle. This is the pemphigus foliaceus clinical. You can see the superficial erosions, the crusted plaques, and the superficial crusts and erosions. It is very less likely to find a intact bulla in this case. You can now find here the subcorneal location. You can see the acantholytic cells. Okay. Pemphigus foliaceus, again, there is minimal split. This is the early case of pemphigus foliaceus. Now pemphigus foliaceus endemic. This occurs in Brazil and Tunisia and other countries. There again, the morphologically it is same, but it is etiology is, it is related to, exact etiology is not known, but attributed is a bite of a particular fly. Now coming to a rare recently identified condition, that is IgA pemphigus. It has got many pustules here. So here the IgA deposition is there, that can be inferred only after you do the immunofluorescence studies. The fishnet appearance, that is classical of pemphigus, in which the IgG is deposited. Instead of that, you will find IgA deposition. But its morphology, histology is like a pustule. So there is no suprabasal cleft is not there, acantholysis is there, but this may be considered sometimes as impetigo, but there won't be presence of any bacteria there. So it differs in from other conditions. And next we come to important condition, that is paraneoplastic syndrome. In paraneoplastic pemphigus, there is severe stomatitis. This is very much, this involves the mucosal surfaces. That's how it differs, and the mucosal surfaces are very important. And they may be the, just as like other paraneoplastic syndrome, they may be the first manifestation of the underlying neoplasm. Now with this we have come to actually some intraepidermal lesions we have finished. So about half of the part is finished, wherein we have seen the immunobulus disorders occurring in the intraepidermal region. And the suprabasal is pemphigus vulgaris and subcorneal is the pemphigus foliaceus and its variants. Same is applicable for pemphigus vulgaris also, its variants. Both are intraepidermal. There are other causes of intraepidermal plus disorders, but we cannot discuss certain them here. But now the subepidermal immunobulus disorders. Subepidermal bullous disorders, they are definitely below the epidermis, or they are present at the region of the stratum basalis or beneath it, the deep dermal or rather deep upper layers of the dermis, which is anchoring the epidermis to it. Now this can be, usually these are associated with inflammatory changes and one or the other type of cell infiltrate is seen, but again a few certain cells only have a very specific presence, otherwise there is overlap exists here also. So eosinophil rich, polymorph rich or the lymphocyte rich inflammatory subepidermal immunobulus disorders and some quasi-inflammatory. Now this being subepidermal in location, you cannot move it. So Nikolsky sign is not present and you get tense blisters along the dermoepidermal junction. Both inherited and acquired alterations in key adhesion proteins at the dermoepidermal.
Dr. Dharpure, we are running short of time, so I think
actually this part is very less compared to
okay,
the first.
Okay, fine, thank you.
Both inherited and acquired alterations in the key adhesion proteins giving rise to tense blister as against the placid blisters of pemphigus vulgaris because they are subepidermal, very easy to understand. Okay, nobody told me about. I am having bad throat actually for last so many days. Okay, we'll skip this because of lack of time. We'll go to the important condition, the prototypical illness of tripedermal, subepidermal lesion, that is the bullous pemphigoid. This occurs in the elderly, that is in the 7th and 8th decade. So the age group is different than pemphigus vulgaris. Tense blisters are produced and articular plaques are produced. More than 50% of these patients are also associated with neurological disease. The typical cell that infiltrates in these is the eosinophils. So for at least this disease, there is eosinophilic infiltrate inside the blister as well as in the dermis. This is the typical gross appearance of a bullous pemphigoid. Clinical appearance of bullous pemphigoid, large bullae are present, some of which are ruptured. You can see here. It can grow up to a very large size because it is subepidermal. So yes, there is a major trauma, it won't break off. The diagram shows the same. You can see, appreciate the many tense blisters, the region of the face. Now this is the microscopy, subepidermal blister. You can see the eosinophil rich infiltrate in the blister cavity as well as in the deeper portion of the dermis. It is common, eosinophils are present. This is the master diagram in which all the features are shown. Tense bullae on the hand. Then this is the peribullous phase of the disease in which eosinophils are present at the dermoepidermal junction. You can see here the eosinophils are present and some amount of spongiosis is present. Here you can see the cell-rich variant and subepidermal blister is getting formed. You can see that somewhat ill-defined subepidermal blister in its formation stage. Sometimes, of course, just as there are overlaps, sometimes the pictures are not very classical every time you expect. And sometimes you may get cell poor variant of bullous pemphigoid. One variety which is very interest to us is the pemphigus gestationis. This we will see in pregnancy 3rd trimester or in the puerperium. The immune deposition is different and it is confirmed by various immunological tests. Now this condition is pemphigus gestationis and that in the mother has caused neonatal bullous pemphigoid. By passage of, this is vertical transmission of immunological disease. So just as RH, in RH incompatibility we have got transmission, similar mechanism is responsible. Now having seen previously the eosinophil rich infiltrates, now we'll see a few of the neutrophil rich infiltrates. The first one is the cicatricial or mucosal pemphigoid. This variant is important because it very commonly affects the eyes. So oral mucosa is involved in almost all cases, but ocular involvement occurs in up to 75% of the cases, and also the skin is involved. So these are the photographs of the same patient. It's his initial presentation and then follow up with an acute exacerbation. You can see here there is no bulla to be formed here, but microscopic changes would be there. And 1 week follow up, you can see some improvement, and then uncontrolled and recurrent ocular pemphigoid at the 9 month. So it also involves some deeper structures like larynx, esophagus, nose, aorta, and anus. The cicatricial pemphigoid, the name itself suggests that it will heal with a lot of fibrosis. You can see the fibrosis that is occurring here, and instead of eosinophils, which are classical of pemphigoid, here you are going to see the neutrophils and the otherwise inflammatory response of other healing process. Next is linear IgA disease. It is seen in children or adults. It is acquired usually because of drug induced, most commonly vancomycin. Linear IgA disease, when it occurs in children, it is called as chronic bullous dermatosis of childhood. That is CBDC is the acronym, and it is drug related to vancomycin, and it produces a very specific sign, that is a cluster of jewels. You can see those clusters here that are formed, and they contain neutrophils plus eosinophils. Next, we see another condition in which you will find a lot of neutrophils, the bullous lupus erythematosus. It is SLE presenting as a bullous disorder. There are two types. Type 1 is similar to EBA, that is epidermolysis bullosa visita, and second is extensive vacuolar alteration at the DEJ, that is the classical type. The important thing to look for here is the nuclear dust, the neutrophils, and the dermal mucin, which is common with SLE. This diagram is showing you neutrophils and some amount of nuclear dust here, and dermal mucin. Here pale staining. Next condition and the last condition is the dermatitis herpetiformis. Here intact vesicles are rare in this condition. This actually has gluten sensitivity. So it's in India it is not very common because it can be proved. Secondly, it is intensely pruritic. That's why it causes excoriations, and intact vesicles you won't find. There are neutrophil abscesses at the tip of the dermal papilla. So neutrophils are there, and their position is also specific, that is at the tip of the papilla. There is granular IgA, also deposition occurs at the papilla on direct immunofluorescence, and anti-TTG antibodies are also present. On gross, you will find that only the vesicles cannot be seen. Only their symmetrical distribution can be appreciated over here. Small sized vesicles, but actually vesicles are not seen, they are all broken. Same. Dermatitis herpetiformis, the typical appearance of an early lesion where neutrophilic collections are seen over here at the dermal papilla, and some nuclear dust is also present. With the master diagram or collage of dermatitis herpetiformis showing erythematous excoriated papillovesicles on the extensor aspects of the forearm. This is the peculiar distribution. You can see the dermal abscesses at the tips of the papilla here. Lastly, epidermolysis bullosa acquisita. This is a acquired condition, and it is produced because of trauma, unlike the other epidermolysis bullosa conditions. So in this case, there is very little inflammatory response. Okay? So it is called as quasi-inflammatory, and there is empty blister may not contain anything, and it has got those dermal papilla.
Dr. Nagpur, I think we should
Finishing
conclude soon.
Within 1 minute. You can see there is festooning. This phenomena of festooning can be observed over here. And that is my last slide. Blistering diseases, subepidermal, they may be inflammatory or quasi-inflammatory. Eosinophils will be dominant in bullous pemphigoid and its variants. Neutrophils will be dominant in dermatitis herpetiformis and LAD and bullous LE and mucous membrane pemphigoid. Lymphocytes, they may be seen in other conditions which were not part of this lecture, and quasi-inflammatory epidermal lysis bullosa acquisita, which is immunological in origin. Rest of the conditions that are not covered are not non-immune types. And thank you and sorry for the not keeping the timing.
Thank you, Dr.